Good afternoon, everyone. Welcome to the February Learning Forum. I am admitting people in from the waiting room right now, but please enter your name and agency in the chat as you enter. Okay, I think we'll go ahead and get started. Welcome to the KPQC Learning Forum for January. I'm Tiffany Burrows, and I am going to be running the Zoom. If you have any questions, feel free to put your question in the chat, or if you're having an issue. And I'm going to hand it over to Tara to get us started for our meeting.
Hi, everybody. Happy February, but barely. We almost made it, everybody. We almost made it. So glad you're here to join us. We have phenomenal content today, so we're not going to spend much time on for trimester information today. A teaser for next month is that we're going to roll out some really important and up-to-date data so that we can look at state data. You guys can figure out again how to look at your county specific data regarding perinatal health. Sometimes that's not fun to do because you find some things you didn't want to find, but every year around this time we go back and look at data, and it's time for us to do that in an exciting and fun, nerdy way in March. But a couple of real quick things before I turn it over to these phenomenal guests today. Next slide, please. That's just a reminder about who's here to talk to you. I'll introduce them again in just a second. So exciting next steps for us, just again, so you know kind of what's going on at our level. Birth equity training. All of you, every single one of you that responded to the champion survey, as well as many of you in the KPQC elective have requested birth equity training because it is really, really good. The Kansas Birth Equity Network has nailed it, and nailed it so well that we're trying to figure out funding streams to get as many people as quickly trained. And we're looking at a very similar parallel training from, we're going to call it inpatient to outpatient side, like we did with post-birth. So stay tuned. We are working actively on that and hope to get that out in the coming months. New enrollees, we have one hospital that's literally sitting on go. So that's exciting. We'll be at 31 at that point, and 2 more hospitals that have reached out just within the last few weeks and are interested in enrolling. What that says to me is that there's some bilateral pressure, and that's not a bad thing. Some at the top level, Karen Brayman, who once again is our marketing strategy guru, has talked to a lot of the CEOs and said, I'm sorry, I thought that you wanted to improve perinatal health in Kansas. And sure enough, the answer was, I did. Let me talk to them. And then Karen sends them off to me and we get some more hospitals involved. The other thing is many hospitals are hearing about you all's work, interested in why they're not already part of it, and come to find out they want to be. So long story short, we're still enrolling hospitals, and we will continue to do so, but that's good news. And then divide and conquer with Team FTI. What does that mean? Next slide, please. Introducing one of our own, Carrie Smith, who is adjusting her picture so everybody can see her now. Carrie Smith is a well-known face and name to the Fourth Trimester Initiative, and certainly the KPQC. Carrie now is on as a staff member. So welcome, Carrie. We are so thankful. Jill and I are so thankful that you took a deep dive with us. Carrie certainly brings a wealth of knowledge to our group in this capacity on the administrative side. And I'm going to let her and Jill actually take over a little in March on those pieces. I call it Team Fourth Trimester Initiative, but quite frankly, it's not just Carrie and Jill and I now. I want you to hear us say that the state has supported sustainability of the perinatal quality collaborative work, and that speaks volumes to what's happening across the state. It also means that our executive committee continues to grow and flourish and figure out where we should aim our work next. And this is how it should be. We shouldn't just focus in on one initiative, walk away, and hope that things end up okay. We should continue to add staff and sustainability and focus in on all perinatal concerns across the state of Kansas. So all that to say, Carrie, we're glad to have you. Next slide. I have started contacting a couple of you, have some sites now, some counties that we are going to hone in on hospital discharge collaborative model outside of your facility. So in other words, she screens positive for mental health needs. She screens positive for needing family planning services. Who are you contacting prior to discharge? What's the handoff agency in your county? So Gary County and Cali County are meeting soon, and we're excited to get that started. The other 7 of you we will meet with in the coming weeks and months as well. Next slide. A big, huge thank you to these 4 champions. They took a big bite at the data collection tool that we're using. The goal, you all, was to go from the Microsoft Word quarterly reports that I used to send out to a streamlined online, easy to access data entry piece. And so Bobby, Chandra, Chelsea, and Carrie have all trialed it out. We're going to meet after this meeting today and kind of work some more on that. But next slide, please. These are the folks that I need outside of that cohort of 4 and outside of the group that has turned in their documents. I need these hospitals to please submit your documents so that we can get everybody queued up and ready for that online system called QHI. The 4 on the left received an email from me about exactly what I need. The 1, 2, 3, 4, 5, 6, 7, 8, 9 on the right are just an addendum only. You're already in QHI as a hospital. We just need the addendum signed. So again, we're ready to roll. In the next month, we're hoping at our learning forum in March, we roll out exactly what you need to do to begin to submit data to us. Again, our goal is that it's very simple and streamlined from you all. We will continue to make sure it is. But we need you all onboarded with those documents before we can do so. Next slide. Whew, that was faster than I've ever done that. 7 minutes in. A PR. I've been up since 2 with a baby. Mountain Dew's working. With that, we wanted to introduce our KCC folks, as you all well know, connect us with lots of important concepts and uncomfortable concepts sometimes about how to improve maternal and infant outcomes in our state. And this is a layered piece of that. And so without further ado, because these speakers today have lots of different angles to show us, I looked through their PowerPoint and I can't wait to hear the information myself. I'm going to introduce our KCC champion, our lead from that group, a member, this is surrounding maternal mental health, substance abuse, mood disorder, but quite frankly, perinatal care, and Jennifer Wise. Take it away, Jennifer. Introduce your colleagues, please.
Thanks, Tara. As Tara mentioned, we know that this is very multifaceted work. This is definitely not all-inclusive, but it is a huge piece of the puzzle. And it's a difficult piece based on what we're hearing from providers that we're working with on implementing substance use screening and maternal mental health screening. So we've been working really hard on this presentation and this content with KCSL and DCF over the past few months. And we have representatives from both organizations here who will be co-facilitating this training. I will turn it over to Rochelle to begin the introductions and then let them take it away.
Well, good afternoon, everyone. We are super thrilled to be invited to be part of sharing our collective information with you all. We look forward to the questions you may have and continued partnerships after this. My name is Rochelle Soden. I'm a training manager with Kansas Children's Service League and oversee a lot of our statewide prevention efforts and training programs. And my colleague that you'll also hear from today is Adrienne Ralston. Adrienne, I don't know if you want to wave, just for sake of time. I won't have us all come off mute at the moment. Adrienne is a training specialist as well. And then our DCF partners that we have worked very closely with on aligning all of our training content and material. Erica Hunter is going to take it over here in just a minute. And Erica is the deputy director with DCF. And then her cohort is Kylie Fry, who I'm not sure if Kylie was able to make it on today, but she's definitely been a very large part of this project as well. So I'll have you do a next slide because I'm not used to doing that. I'm used to controlling slides. So if you can go next slide, there's a little bit on Erica and Kylie. And the next one will have Adrienne and myself on it. And we partner as Kansas Children's Service League. We're the state chapter for Prevent Child Abuse America. And so with that, we partner with all of our different state agency partners to really move the work forward of protecting and promoting the well-being of children. So with that, you're going to hear from Erica first and me second and Adrienne third. So Erica, I'll let you take it from there with the next slide.
All right. Thank you guys for all being here today. And just know that this is actually our first time presenting this. And so we appreciate all the grace that you will give us as we, or me, I know I'm going to fumble through it. So thank you all. And I'm really excited to be presenting this information. I've been passionate about it for years. And so you'll probably hear some of that as we go. I also talk very fast. So if you don't understand something, please just feel free to put it in chat and I will try to go back to it so that you get it. So learning objectives today, we're going to talk some about mandated reporter training, period of purple crying, and then supporting families. And how do we do that? So next slide. Okay. So first thing is going to be about mandated reporter training. Oh, sorry. It looks like one of our slides disappeared. So I'm just going to tell you some stuff. You don't see a slide, but that's okay. So mandated reporter training. So if you are on this call, then you are a mandated reporter. And so what that means is when a person has reason to suspect that a child has been harmed as a result of physical, mental, or emotional abuse or neglect or sexual abuse, the person shall report that matter promptly to DCF and/or law enforcement. And so one of the main things that I want to tell you about this is just DCF, we are not emergency responders. So if you ever have a situation that you are needing to report on, you suspect abuse or neglect, you feel that child is in immediate danger, them leaving your office is going to put them in harm's way, you would want to contact law enforcement. Law enforcement can come out and do an immediate assessment on that family to determine if there's any sort of protective action or if there's some sort of immediate plan they should make for the safety of that child. If you do have to call law enforcement, you should also still make a report to DCF though, because DCF and law enforcement have two very different roles when we work with families. And so law enforcement may deal with some immediate issue, but DCF would then deal with the family kind of on an ongoing basis. Next slide, please. So when I said earlier, part of reporting goes back to when a person has reason to suspect abuse or neglect. That can sound kind of, how do I know if I suspect abuse or neglect? So we're going to kind of walk through a little bit of that with you. So reason to suspect is really about whether or not you have information to say that you think somebody has been harmed due to abuse or neglect. So there are times that you could see something that is not that you immediately look at it and think, oh, this seems like it's abuse. But if you ask a couple of questions, you realize that no, this wasn't abuse. The example I always give is seeing a kid that has a black eye. Just because a kid has a black eye does not mean that that black eye was caused by abuse. And so if you see that, you're going to ask a question. What happened? I see you have a black eye. What happened? If a kid says to you, well, I was playing baseball over the weekend and somehow the ball hit me in the face. Okay, that makes sense because I could see how you maybe get a black eye from being hit in the face with a baseball. But then on the other hand, if the kid says to you, well, I got hit by my younger sibling with a pillow, that doesn't make sense to me. And so you kind of had inconsistent information, inconsistent stories. And so then that can lead you to say, well, this information I have, maybe the inconsistent information, the child's behavior, leads me to believe that I suspect abuse or neglect might have happened because this does not match what I'm seeing or the information that is in front of me. And you don't need all of the information in order to say that you would suspect something happened. You just need to have the basic information to say that you suspect abuse or neglect happened. I know that sounds so vague, but it's really about some of that critical thinking when you have a situation. What is it that makes you think that is abusive or that is neglectful? And so we always say, it is okay to ask some additional questions if you need to. Just avoid feeling like you need to do an entire investigation, or don't feel like you should never ask leading questions. So examples of leading questions are, Did your mom punch you again? Or did your grandma do that to you? So don't put that, thought into somebody's head. It's really just asking open-ended questions. Tell me more. What happened? I see that you have this injury. Tell me what happened. And so again, it's okay to ask questions. Don't feel like you need to investigate it, but just don't ask leading questions. Then when we think about sometimes within your own local agency, you may have different policies that people have that when it comes to reporting. So some of the things we want you to know is that nobody should ever stop you from reporting. So your employer should never tell you that you can't make a report. You should never have, your administrator at your place of employment tell you before you make a report, you have to get approval from me. If you feel like you need to make a report per Kansas statute, you're supposed to make a report. So again, you should never have anybody try to stop you. If you do, what kind of conversation can you have with them about what mandated reporting is? Is there a way to talk about having mandated reporter training for your agency? KCSL does that with individual agencies, or they have the monthly that they do. So that could help educate people. You should never have ill consequences for making a report in good faith either. So nobody should ever discipline you. You shouldn't be terminated from your job. You shouldn't be written up if you made a report out of good faith. So if you ever do have things, I have had people reach out and say, they're trying to say I shouldn't have made a report. What can I do? And we can help give you statute, and talk you through some of that stuff. So then another one we oftentimes get is just, who really should make that report? And what we tell people is the person who has that firsthand knowledge should always be the one who makes that report over people that kind of got told that information down the line. Because I want you to think of, the game telephone when you were a kid, and the first person who said the sentence or the story that's supposed to be passed along, by the time it gets to the fifth person there, that has completely changed. And now think of that as something that is about a family. It's not a one sentence. It's a, several paragraph long concern that somebody has, and how that has changed over time with the different people's interpretation of what they heard. And so again, it's just really important to make sure that whoever it is that saw what happened, observed the injury, talked to the child, talked to the parent, those are the people that should be making that report. And so you can make a report with another person. So if you have the parent in there with you and they're willing to you've talked to them about that you're going to be making a report, how do we help get support for you as a family? Let's make this report together. That is okay to do. If you have doctor, nurse, and social worker all kind of working together, and social worker and the nurse want to make a report together, you can do that. And so again, it just goes back to the person with the firsthand information is the one that should always be making that report. And I know sometimes it gets hard and we have all kinds of questions about, well, what about if we know two other people have already made the report, and am I supposed to make a report? Per statute, as a mandated reporter, everybody's supposed to make a report. But really it's that person with the firsthand information that needs to be making that report. So next slide, please. All right, so I know that we're here really to talk to you guys because we want to focus more kind of on the work that you guys do as the perinatal providers, specifically when it comes to substance use that you might be concerned of a person using. So there is a workflow that has been developed that I know somebody's either going to email you guys or somebody might be able to put in chat. I don't remember how we talked about that, but there is a workflow that is available for all of you. And it goes into a lot more detail than what you're seeing on these slides. And it really talks about kind of what is it that when you have a person who's in there and you're concerned for potential substance use, what should you be doing? What kind of screening, what kind of action? So that could be that you're concerned either because maybe a person admitted to use, maybe a person is displaying behaviors that you're concerned with, or maybe they had a UA somewhere and you found out that that person is positive for substances. And so now we know that we're concerned. And so how can we, what can we do for that family? So first is kind of administering a screening tool that can help you ask some more questions about what that substance use looks like. And I know that information is on the tool, and KDHE has additional resources for everyone. So I'm not going to go into that today, but that is available so that you guys can get some more information on that. So first is really thinking of what kind of screening tool that can we use to assist that family. And then it's thinking of, well, what really does this family need? So I've identified on this tool that the parent does have substance use. Maybe there's a low risk, maybe there's a high risk, but still, no matter what is it that that family needs and what does that look like? And so some of the things that you'll be kind of talking about with them is kind of what is their willingness to participate in treatment? And so what does that look like? Is there a way for you to assist with making a referral to a drug and alcohol treatment, or providing them additional information on what there are as far as resources that are available? And so, we know that sometimes specifically with some substances and pregnant women, it can be a difficult population depending on the substance. I mean, with DCF, we see pregnant women who maybe are using meth. We don't see them oftentimes getting a whole lot of prenatal care. We don't see them really showing up at the hospital until they've had some sort of an emergency. And then we get a report that they're pregnant, they're due in 2 weeks. We can't find them again oftentimes until they've then had the baby. And so there's certain, things that we see with some substances that it's more difficult to kind of engage with those families, but you may have that one shot. And that's what we don't want to lose, is that one shot that you might have. If somebody's in your facility and you're concerned, what can we do to support them in getting that treatment and being a sober parent? And so this is why we say, evaluate that family's needs as far as what you can do. So I'm going to go in a little bit more about thinking of, well, when do I make a report to DCF? Because that's really what we're here to talk about, is like, when should you be making a report to DCF when it comes to the substance use that you might see with a family? So next slide, please. So when I was putting this together, in my head, I could think of, you guys have a wide variety of different people that you potentially are going to make a report on. A lot of times we're kind of just over in this the last two category, but you're unique because you do have more contact with all different populations. So you potentially are going to be making reports with pregnant women who are using substances, infants who are born positive, just concerns for parents using, or potentially abuse or neglect of newborns or siblings of that person that you're interacting with. So the first one I'm going to talk about is the pregnant women using substances category. So this isn't something that is in statute as far as mandated reporters have to report on reports when they interact with somebody who is pregnant and using substances. But it is an area where DCF does offer services to families. So we do have specific programs that we can refer a parent to when we have concerns that they are using substances. But as I said, a lot of times when we end up getting involved with the pregnant women using substances, it is usually the families that are, they have a lot of other stuff going on. They have a lot of other risk factors than just that parent is using and they're pregnant. So with the pregnant women using substances, what we talk about a lot of times is, okay, so is the pregnant woman using and they're lacking that support for treatment or recovery? Is the pregnant woman using and there's a concern that's going to impact the child when they're born, or it's currently impacting their family right now? So, when thinking of substance use that a pregnant woman might use, we hear frequently pregnant women use marijuana, and oftentimes their doctors are aware of it, and there's not a concern from the doctor for that woman using marijuana. So there's nothing that says you have to report that substance use. And so it's really going to be looking at a lot more of those risk factors that you might have with that pregnant woman. So if you see, we have a pregnant woman who's using substances, but she's also homeless. She's lacking prenatal care. She has a lot of mental health issues. She's in a domestic violence relationship. Her functioning is fairly low. What are the reasons why we're concerned with her substance use? Because substance use alone isn't necessarily a safety concern. It again is a risk factor. So know that there are services that DCF could offer to a parent, but they're also probably some of the same services that someone else can offer that person. So it's a referral to somewhere. It's help getting them into treatment. If you're struggling with doing that, if they don't seem to be following through, there's just a lot of additional risk factors you have, then that can be something you'd report to DCF, but it doesn't have to be. You guys can support them how you feel you want to do that. So then we have also kind of an infant who is born positive, or maybe a parent who admits to using at the time. So not every infant who is born positive, or not every time a parent reports that they used a drug or alcohol or something, needs to be reported to DCF. So I'm going to go into more of infants born positive here on the next slide, because I want to kind of distinguish out a couple of things with that. So hold that one, and then we're just going to talk about the last one, which is abuse or neglect of newborns or siblings. So there are a lot of times you are going to be working with a family, and when you're working with them in the capacity that you are a mandated reporter. So that means that if you have concerns of abuse or neglect of any of those other children that might be part of that family, then you're mandated to report. And so at DCF, it goes back to that. What do you suspect is happening? What is it that makes you think that there is abuse or neglect? Are you seeing, when mom had the baby, she came up to the hospital and her other kids came up with dad and her were getting into arguments. The other kids appeared to, be very dirty and didn't look like they'd been taken care of. Dad ended up getting kicked out of the hospital. What all is happening that makes you concerned for potential abuse or neglect? And it's not necessarily only about that newborn, but it's also about those siblings. So what are the caregiver's actions, I guess you would say, and what is the impact from maybe that parent's substance use that has you worried? So, so there's just a lot of different things. You see such a variety of different cases that you might be needing to report on. All right, so next slide. And now I'm going to break down a little bit more when we talk about infants who are born positive for substances. So I'm trying to think, hopefully this is going to make sense, but it's sort of confusing. So I'm going to try as much as I can. So there's federal legislation that is through the CARA Act, and boy, I just lost that acronym out of my head here right now. CARA is part of CAPTA, which is all federal legislation, and CAPTA is the child abuse. It's what we have to follow. I've lost all my acronyms right now. I don't know what happened to my head. Sorry. So anyways, so we have to follow all of these. And so several years ago, they put in new legislation that was about infants that are born affected by substances. And so in Kansas, for a long time, we have always assigned reports, or at least received reports that were about infants that were positive from it. But then it became this differentiation between infants that are affected versus infants that are just positive for substances. And so that's kind of this distinguishment that we have here. So you are required to make a report on an infant who is affected by substances. And in Kansas, that is defined as the birth of an infant who is identified as being affected by or having withdrawal symptoms resulting from perinatal exposure to legal or illegal substances. And it lists out examples of what those type of withdrawal symptoms might be. And so that is something as mandated reporters, it's in statute. It says you shall make a report if you have this. And a lot of that goes back to the CARA Act and them wanting to have, they want to have information to know how much is substance abuse impacting your state, specifically children that are young. And so with substance affected infants, one of the other major differences is that we have to do what's called a plan of safe care with that family. And I'm not going to go into all the details of what that is, but a plan of safe care is DCF works with that family to talk about how are we going to help parents stay sober? How do we help prevent relapse? What does that child or infant need? And how do we keep that infant safe? And so they would develop a plan. And, with CARA, the goal, what they would love to see is how do DCF and medical providers work together on this plan of safe care? Even thinking of, when before a child's born, how do you develop that plan of safe care? How do we assist with seeing that this parent potentially is sober by the time that that child is born? And so really they envision a plan of safe care as something that is a lot of different people working with that parent to be able to provide that. So substance affected infants is, something that you would report on if there are withdrawal symptoms resulting from that prenatal exposure. So we do still have some infants who are positive for substances, or we know that there's substance use that has been done, but we don't see any effect. And so with those, it is not a requirement that you have to report. So for marijuana, for example, I know working in the field, working at the Protection Report Center, we would see a lot of reports that come in concerned for somebody is using marijuana. And a lot of times with those reports, we didn't really have any safety concerns for the child, nor do we really have many risk factors. It was just the person is using, and therefore it prompted a report and it prompted DCF to go out. And so what we really should be looking at is, what the safety of that child. So one of the questions we might be asking you as a reporter, or a question for you to think of as you are making a report or determining if you should make a report, is on a scale of 0 to 10, where 10 means the child is completely safe right now, and 0 means that if no action is taken, the child can be seriously hurt or injured in the next day or two, where would you rate this situation? So just having an infant that's born positive with marijuana, but you have parents who they've been up at the hospital, they have family that's visiting, they appear appropriately bonding. There's really nothing that you see that is concerned for you. If you're on a scale and you say, well, I'm at a 10 rating this kid for safety, that can help you say, well, I don't think a report needs made, because I'm sitting here seeing that there's all these, these protective factors that we have for this infant, and just the parent using substances does not appear to be impacting their ability to parent. And so that can help you kind of think, or just use that tool to decide if you need to make a report. So again, it's thinking of the protective factors. Are there community referrals that the hospital could make? Maybe there's just a couple of things that that family might need, but they're not really impacting the infant safety. What referrals could the hospital or doctor make for that family? And then thinking of the other risk factors, again, going back to what things do we know about that family that might be a future risk? That, and Rochelle will hear talk about shortly the period of purple crime. What increases that child's risk factors of being harmed? Because we know maybe there's homelessness, mental illness, domestic violence. Do both, caregivers use substances? What type of substance is that? So there's a lot of different things that go into it. And again, that's one where it's not an automatic that you have to report. It's something where you can really think of, what do I know about this family, and what are my safety concerns, and what are things that I have, my risk factors that I have for them. It's really those, again, it goes back to federal legislation, and for substance affected infants, the need to report on those. So again, I know that's confusing, and I will answer questions here in a little while for you all, but I'm going to keep on moving. So next slide, please. So after you guys have made a report, it goes to the Protection Report Center, and there we will make our initial screening decision. We're basically trying to decide, is there an allegation that this meets, and does it need screened in or screened out for further assessment? So at DCF, we assign about 55% of the reports that we receive in, and the other 45% are screened out for various reasons. Either we've already received the report, family already has services, or it just doesn't meet a definition for us to assess or assign for. So, all right, well, the next slide is going to be a video that we are going to play. And this is a video that's just going to explain a little bit more about the work that Kansas has been doing over the last few years. It's called our Kansas Practice Model. And so I'll let you guys watch that. Oh, I think it's supposed to have sound.
Sorry, guys, hang on one second. I can hear the sound, but apparently you cannot. So give me 1 sec here. Tell me if you can hear this.
Yep.
At the Kansas Department for Children and Families, we believe working alongside families and communities is the best way to achieve our mission of strengthening families and ensuring children are safe. We've strived to develop a way of doing our work that includes and honors the voice of families and children that partners with the strengths of our communities. Using a family-centered approach, we strive to work alongside families, their natural supports, and the community in which they live to improve safety and overall family well-being. Practitioners engage with families to identify together what supports may help them reach their goals as a family. What we believe: every person has the capacity to progress, succeed, grow, and to do well in life. We care about each other and the people we serve. Each person is the expert of their lives and has a voice, choices, needs, strengths, and life stories. We honor and respect the voice of the people we serve.
I think the sound disappeared when you muted.
And the solution is different for every family. If we focus on identifying and meeting the goals and needs of parents and caregivers, they will be better able to meet the needs of their children. Practitioners help families access needed supports to meet their own goals. Nothing about you without you. We believe Kansans have the capacity to thrive and do well. We will continue to walk alongside with respect for the families we serve through the challenges they face.
Thank you for playing that for us. So, just a little bit, DCF has gone through a lot of kind of rethinking how we work with families over the last few years. And that video just kind of sums it up. And I can send that video to you as well if you'd like to watch it outside of here. So when we think of DCF working with families, it used to be, it felt like we were always building cases against families, that we were getting information to be able to point the finger and say, hi, gotcha. But that's really not the work that we want to do with families. We know that that doesn't get us where we want to be. And so it is really more of a shift of, instead of building cases against families, we're building safety with families. And so we're working with the families to really look at how do we use their natural resources, their strengths to build that safety. Next slide, please. And so we do a lot of community service, a lot of service referrals. So whether that be community referrals, family first prevention services, family preservation, or foster care, we're always trying to figure out what it is we could do to help that family. And I won't be able to go into a whole lot of detail about these, but we do offer just a lot. And people think of DCF as being foster care, but really a very low number of families that we actually interact with end up needing foster care as that final solution. Most of the time it is community referrals that we are doing, and it's a lot of the same people that you guys are going to be referring to. So those same resources in your community you're using are the same ones that DCF is using for those families as well. So just a few final tips. Oh, sorry, next slide. I'm looking at my own, forgetting I need to tell you. So a few final things is when you make a report, please make sure you're including your email address, all your contact information. That way you'll receive your intake ID number that you'll get after. You can also have your client sign a release of information. So that way DCF and you can collaborate and again, partner, streamline, work together to build that best network for that family. And that goes back to even thinking of, you can make a report with that caregiver. If you're having to have the conversation about substance use with them, what does that conversation look like about talking about mandated reporting and how you can support them and maintain that relationship by having that conversation. You can also contact their provider consultation line for perinatal behavioral health for resources and referral assistance. And to request training or to schedule a substance abuse screening implementation consultation. So just some additional things for you guys. And I am going to pass this off now to Rochelle to talk to you more about some of the period of purple crying.
Awesome. Thank you, Erica. So I was looking through the list of who's attending, and I'm so thrilled that I recognize so many of you from past projects or other capacities that I've worked with. So I'm going to briefly talk about the period of purple crying and how we can prevent infant abuse, specifically abusive head trauma, which is also known as shaken baby syndrome. Because when we're really looking at substances and their impacts with families, particularly families with new infants and newborns, we know that the first few months of having a new infant is already stressful enough. And then when you add in impacts from substance use and some of the other risk factors that we've been mentioning through Erica's section, we know that there's just an increase for having some bad things happen. And so we want to make sure that everyone's familiar with the period of purple crying, and we have a whole training just on this. So I'm going to give you a very condensed snapshot of what this is, and many of you are already familiar. So next slide, please. Real briefly, we know that shaken baby syndrome and abusive head trauma happen. It's thankfully not a large percentage of our abuse cases, but any one case is one case too many because of the very detrimental effects that take place. We also know a couple of specific things with abusive head trauma in that one is that from normal child development, all infants are going to go through a period where they increase their crying. So if you've had babies, you already know this. It can be as little as 20 minutes per day of an increase, which isn't really noticeable. And it could be all the way up to 5 to 6 hours every day for weeks on end, which can be incredibly stressful, particularly if we have families who are already with other struggling areas of risk factors. What we also know is that shaking most often occurs in response to a baby's crying. So that's the stimulus because of the frustration, the exhaustion, the not, being around a baby crying for 10 minutes is stressful, let alone for 5 to 6 hours. So the bottom line with shaken baby syndrome is that inconsolable crying is the primary reason for why shaking or abusive head trauma occurs. Next slide, please. We also know specifically through our national partner with the National Center on Shaken Baby Syndrome that this increase in normal child developmental crying is absolutely linked with increases of where we find shaken baby syndrome abusive head trauma cases. So the graph on your left is plotting where we know there's all cases occurring that have been related to shaken baby or abusive head trauma. And then that same graph line is overlapped onto the right-hand graph on your screen, which is the purple line. So again, it's a duplicate line there. But then what National Center has done is they've added in where known causes or stimulus are that are related to crying occur. And that's the yellow line. So you can see that there's a sharp peak at the same point, which is roughly about the 8 to 12 week period. And that's where we know that that increase in crying through normal development actually peaks. Next slide, please. What we also know, and it's important for you all to know from the medical side of things, is that there absolutely is diagnoses of shaken baby syndrome, abusive head trauma. There has been some controversy over it over recent decades. But there is a joint consensus statement out there that basically states there's no controversy concerning the medical validity of the existence of abusive head trauma. And you'll have a copy of the slide, and you can see all of the national and international organizations that have agreed to this consensus statement. So I just wanted to add that in because I do think it's important when we're talking to our medical partners. Next slide, please. We know a couple things with abusive head trauma. One is it's absolutely preventable. It's one of the few instances of abuse where we can actually say it's preventable. And the reason we can say that is because it's really the only kind of abuse where we know the two things that are occurring. We know when it typically occurs, which is in those first few months of life, typically. And we also know the why it occurs, which is due to the frustration from an infant's crying. And what we also know is it's 100% preventable. And that is through educating parents about this normal increase in crying that can occur, and making sure parents recognize that it's okay to put a baby down in a safe place and take an adult timeout. Next slide, please. So the period of purple crying is still around. It's been around for, I think, going on almost 15 years now. Many of your hospitals and locations have partnered with our agency over the years to implement and distribute the information. But for those of you not familiar with it, it's an evidence-based shaken baby syndrome program that really looks at doing two things: supporting caregivers in their understanding of this early increased infant crying, and then also and kind of simultaneously reducing the incidence of shaken baby syndrome. It is not a program that takes a whole lot of time to implement. It literally takes about 2.5 to 3 minutes to talk to families about. And it is the most widely researched program in the world, and it's implemented internationally as well. Next slide, please. So the crying curve, just to reiterate, this normal infant crying is that at 2 weeks is when we start to see the increase happen. So if we've got families who are not equipped with supports, who don't know that this can happen, who are dealing with other risk factors, and they happen to get one of those high crying babies, by the second month of life is usually when we see this peak of crying occur. We call it the period of purple crying because it does typically come back down to normal levels of crying by somewhere in the 3 to 5 month mark, give or take. It can be a little longer, a little shorter. So knowing that this occurs, next slide, please. The key messages we want families to have is that crying is normal, and the crying really isn't the problem. The problem is how we respond to the baby's crying. So we've got to be making sure we're having these conversations with parents. And that really relies on all of you who are interacting with these parents who are having new babies or in those first few months of life. Just ask them, do you know that it's okay to walk away for a few minutes, go into another room when the baby's crying becomes super frustrating? You don't have to keep trying to hold the crying baby and soothe it at the same time, because that can be a recipe for disaster. Do you have a plan of what to do if your baby goes through a period of high crying? Do you have a resource? Do you know who you can call? Do you know you can call your pediatrician? So making sure we're asking parents these questions is really, really important. And then next slide. And then we want you to be able to use the program materials, which we can supply these to you. Many of your hospitals are still distributing and implementing the program materials. If you aren't and you used to and you want to restart, please get in touch with me. We will happily get you going with that again. Next slide, please. But ultimately, with using the information, we want to make sure families are getting this information, their own program materials. It's super easy for you to implement. Again, takes less than 3 minutes. For sake of time, I'm not going to go into the details. I'm going to have you fast forward 2 slides actually to the teach back. Yes, what we want you to be doing with any program materials that you are trying to help your families understand is what we call a teach back method. So whether that's purple, safe sleep, breastfeeding supports, car seat safety, whatever the case may be, we want you to be using teach back opportunities, which take a little bit extra time. And so the example I'm going to give you is very often we all find ourselves in this pattern of giving someone information and then saying to them, do you have any questions? And the person typically responds with, no, I don't have any questions, which is great. But that doesn't actually tell us if the information we've been giving the family was actually received and understood. So you can start with that. That's our default most of us go to. But then when you hear the no, I don't have any questions, try with a follow-up question. Excellent. What would you tell someone else about a high crying baby? Or who would you call if you have a high crying baby? Or what is going to be your strategy for if you have a high crying baby? What are you going to tell your parents who are going to be helping to take care of the baby about safe sleep practices? So just that little extra step of having that conversation with the family to make sure they understand the messages is part of the teach back. So next slide, please. We want you to be able to partner with us We want you to be able to make sure that if you are seeing a family at delivery in the first couple of weeks or months of life, whether that is through a home visitation program, a pediatric program, a delivery program, an OB program, we want you to be able to partner with us. And so we have the program materials available through funders to provide to what we call our Dose 2 partners. Many of the hospitals order materials through the National Center on Shaken Baby Syndrome on their own. So if you don't know how to get them, where they are, who might be the contact, get in touch with me and I will happily help connect you. But we would love for you to be using those materials. And then my last slide before we move to supporting families is don't forget about the dads, because we often focus on talking about the moms because they're the ones who've just delivered the babies, but we want to make sure we're talking about the other parent or the dad or the other significant person who is taking care of that newborn as well. And so it's vital that we make sure we're trying to get the resources and supports to anyone who's going to be taking care of that newborn, whether they're a high-risk family or not. All families need to get supportive information from a wide variety of our programs. We do want to be making sure that we are paying close attention to families that do illustrate and show risk factors, but we never want to assume that lack of risk factors means lack of risk, because we know that that's not the case either. And Brenda has a really great comment in the chat that crying doesn't always mean that the baby's hungry. That's their way of communicating. Absolutely, Brenda. There's lots of reasons. It's why it's stressful, because we're trying to decipher nonverbal communication. And so we want to make sure that we're setting our families up for success, knowing where our supports are. So I will turn this over to Adrienne, who's going to talk about supports here in the last few minutes.
Yeah, so we'll go pretty quickly on kind of this new perspective shift that we're moving forward with on basically how can we support families before the need escalates to making that hotline report. So this more kind of prevention shift, this prevention focus that we're having to these things, because I mean, ultimately, at the end of the day, I want to put myself out of business. I don't want to have to intervene when a child is, abused or neglected. And I assume that that's a common thing. But we want to make sure it's important that we, again, have these protections in place, because they shouldn't always be our first call or instinctive responses, because we have the ability to kind of be that support for that family. And what is best for that family is for them to grow up in those families and in their families and in their communities. And you can move to the next slide, pretty please. And this, and this is why this, perspective shift is important, because when we're thinking about it, we know how to report. We talked about that, or Erica talked about a lot of that. We know a lot about what DCF side of things goes into, but it's more of, do we know how to prevent it? And there's this really good study out there that shows that, actually being, reporting child abuse, it isn't out there to help prevent child abuse. So that's where us as the supporters of family come into play, because we are already mandated reporters, but how can we consider ourselves supporters of family? And I might be thinking, oh, well, you're adding more to my plate, but you already have these tools. I guarantee that you have these tools already for you to take this preventative approach. It's just kind of switching that mindset to thinking about, how can we address those risk factors before things escalate to where I have to make that hotline report? And a lot of the times we have those, those resources already available in our communities and in our systems. It's just being a little more reactive instead of just intervening when we see the need to. And, what does this kind of look like? So supporting families is, obviously supporting the family before that need kind of rises to the need to report to DCF. And there's research out there that shows that, between prevention and like those family engagement strategies, those early intervention services, and being like culturally responsive within our services, all of these things show to prevent child abuse from happening in the first place. And I'm going to go ahead and skip 2 slides for the sake of time and go into skip one more. And go ahead into how we can support families. So this, again, how we can start switching our mindset to this perspective shift. How can we support families in our community before that need escalates to that hotline report? So thinking about what type of resources can you connect your families to? Do you know where to refer families to for rental assistance? Do you know where food banks are? Applying for medical coverage is really difficult. What resources do you have in your community that are available to assist with that? Thinking about those mental health resources, childcare Aware is a great resource as well, but also also, substance use resources, and 1-800-CHILDREN can be a really great starting resource for you. But we basically just want to help creating this, thinking about how we can partner with the other community agencies within this community to kind of create this community that is rallying around these families, because that's what we want to do. We want to rally around these families, support them, and help and elicit the help that they need within other community resources, rather than just relying on DCF solely as that first or initial call, because DCF is great at what they do, but we can also help alleviate the burden of helping them before we need to make that report, because we have that ability to do so as well. And I'm going to go ahead and skip the next slide and go to 1-800-CHILDREN and talk briefly about that, so we have some time for questions at the end. But this is a really awesome resource that I think everybody should have at their fingertips, literally, because it's an app that is really wonderful. But at its core, 1-800-CHILDREN is this judgment-free parenting support hotline that you can give out to the parents that you're working with. It offers just that judgment-free support where they can call in with any type of questions. No question is off limits type of thing. There's different. It's available in 200+ languages, which is really awesome. But where I really appreciate it is from the community provider, or the service people, and the people like us in the communities, the people that are working with families. Because what's really awesome about it is you visit the website or you download the app, you type in your zip code, and it's going to directly link you to every single service that you have available in your community. So it's going to be, you can directly filter it to helping with, whether it's monetary assistance, rental assistance, and need help with mental health services, anything along those lines. You're able to get them connected so that we can help address those risk factors that we do see in order to help prevent, obviously, this abuse from happening in the first place. So that's where I really appreciate 1-800-CHILDREN. You can contact the contact right there if you want to get more promotional materials. We have magnets, we have flyers, which is or if you want a presentation about 1-800-CHILDREN, definitely follow up with that. But this is a really great resource for children and families to have in order for us to be supportive entities within these communities. And with that, I'll leave the last 4 minutes for questions, because I'm sure you have some questions, and we would love to hear them. So you can go to the next slide.
Sarah, if there aren't any questions, is there anything that we need to say in follow up?
I'm getting a lot of sidebar questions about sharing this out to the individual hospital, so staff, other agencies, and the answer is 1,000% yes. You can tell that this is a well-attended learning forum, and thanks to our presenters, because they're and as obvious as the algorithm is, I would tell you at the bedside at 2 o'clock in the morning, this is a hard call for our nurses, our providers. What do I do next? And when I see or I'm concerned. And so the answer is, let's share this out to staff. Let's help everybody understand the algorithm. And if there are questions, reach out, certainly, and get some more people involved to help families. That's a great way to put that. So this PowerPoint and the recording will be sent out. Tiffany's awesome about that. And you guys, please send it out to your staff, have it as mandatory education. I would love that for you all, but you bet. And then I'm assuming that the presenters are okay with direct contact or questions as follow-up. Is that okay? Yep. So Tiffany, remind me, we'll send that out as well, their direct emails. Let me stop. Are there questions? Probably a lot. You're probably thinking of cases. I'm guessing you're thinking of some cases that you weren't sure if you did the right way, or that you wish you would have done a different way, or maybe this is clarifying or more medi. I don't think that taking care of families has ever been clear.
Tara, if I can jump in quickly.
Please.
If you all do have questions, we recognize this was kind of a brief window to throw a lot of information at you. The KCC team will be pulling in some of our expert clinicians to attend the TA workshop, and they'll be facilitating a continued conversation about what this looks like. We'll go over some case studies. We encourage you to register for that. The link is in the chat. Also, if you have a social worker that you work with regularly, feel free to invite them into that conversation. because we really need a lot of coordination to happen. As Adrian and Erica and Rochelle all mentioned, this is really about figuring out how to create that web of support around families. And that starts with you all being coordinated inpatient with whoever can help you provide those referrals. So if that person is a social worker, please encourage them to come to that conversation for the TA workshop. And that is, I believe, in 2 weeks from today. So register, you'll see another link come out from KCC on that, but please take the time to register and show up for that conversation, willing to have a really good, honest conversation about how this looks in the clinical setting and what your next steps are for screening implementation and connecting folks to referrals.
There's also a question in the chat that I want to address. That's from Chandra Case, and she's asking if all hospitals are educating parents on period purple crying, and the answer is unknown at this point. Right before the pandemic, the shift changed for how hospitals were being provided their materials. Grant funding was lost from being able to supply it at no charge to hospitals directly. And so we worked in a transition period for almost 2 years to get hospitals to move into partnership with the National Center on Shaken Baby Syndrome to purchase their materials directly from them with support from KCSL for training and other pieces of that implementation. We do not currently have an active list of which hospitals are indeed at full implementation and which have dropped off, but I would say probably about 50% of implemented hospitals are not currently under fidelity agreements with the National Center for birthing hospitals here in Kansas. So if you are at one of those hospitals, do not know if you are implementing, please get with me. We will happily help get that figured out and get you re-implemented back. But that has been a shift that's taken place in the last 3 years.
Okay, I will have all of the information available to you all in the follow-up email that usually goes out about the same week. So later this week, you should be able to see that. It will have all the slides. I'll try to get all the resources out of the chat and out of the follow-up information. So let me know if there's something that I missed or that you didn't see in there, and we'll get that added. Thanks, everyone.